Welcome back after morning tea. Now, I think I was so distracted by the address error on the flyer that I was incredibly remiss as the co-convener of today not to acknowledge my co-convener Jackie Yim from the Brain Cancer Group, without whose sort of momentum and persistence and patience, and also his collaborators like Suzanne Paponis, we wouldn't have had today. So big thanks for Jackie. And Jackie's going to be chairing the afternoon session after lunch. Okay. So we've introduced the three speakers from the morning session. We've got two additions to the panel. So we have Dr. Michael Rodriguez, who's a neuropathologist of great acclaim. He's been around for a long time, and he's now what we call a roving neuropathologist. And he really he is involved in so many multidisciplinary team meetings around Sydney, and he's an I think we would describe him as a treasure. So
I'm not that old.
no, the exciting thing about Michael as a pathologist, he actually knows more clinically than many clinicians in the room. His comments about the radiology and the clinical options are extraordinary, and it's wonderful having him. So thank you, Michael, for joining us. And also, I've alluded to Siew Koh before. So Eng-Siew Koh is the chair of COGNO, the Cooperative Trials Group for Neuro-Oncology, and also the chair of the COSA Neuro-Oncology Group, as well as being a hardworking patient-facing radiation oncologist. So welcome, Siew, to the panel as well. So thank you for those of you who've submitted questions. Some of you might find that you have questions that relate to what's being said. If you do have a question, I'm happy for you to raise your hand, particularly if it's pertinent to what's being discussed, and we can sort of change the flow of and address your question as we go. And there are two roving microphones as well. So what I'm going to try and do is I've tried to thematicize the questions. So the first, and also Jacob's got a very busy afternoon, so he might have to duck out during the panel session. Okay, so we're going to start with some causation questions. So this is a question which says, my question relates to the research currently being conducted into possible causes or triggers for brain tumour development. Please talk about any recent discoveries related to causation. So, anyone wants to?
That's a question for our treasure.
Thank you. Unfortunately, in most cases, we don't know why people develop brain tumours. There are certain hereditary conditions that may be associated with developing a brain tumour, but they're really uncommon. So for the vast majority, there are no causes, no things that you could have done differently that would stop you or your loved one getting a brain tumour. Things like radiation can cause brain tumours, as well as being really important for treating them. There was some research a while back looking at viruses maybe causing them, but that doesn't seem to have panned out.
Okay. Anyone else want to add in?
Sorry, and not mobile phones.
That's the next question. So we can do this question right now. The latest information on brain tumours and mobile phone use. Jake, do you want to say anything about that?
I think I defer to the treasurer.
Just say no. A lot of the data was old data when the mobile phones had much more energy. Sure, mobile phones do things to cells in a dish, but the epidemiological evidence that they actually cause brain tumours is very sort of iffy. They may be related to schwannomas, maybe, but different studies show different things. And as you can imagine, they're incredibly difficult studies to do. They're big epidemiological studies. And in a big epidemiological study, when you're asking questions retrospectively, so if somebody has a tumour and then you ask about their mobile phone use, most people can't recall exactly how much they used. And then there are so many other confounding factors, some of which will be taken into account in those studies, but a lot of them won't be. So I wouldn't give up your mobile phone. I don't.
So I guess you've got to look at what is the incidence of radiation-induced tumours and the time frame. So if you think that a mobile phone is emitting radiation, and it doesn't emit the same radiation that we deliver, then it's really a 10 to 15 year lag before you actually get a tumour from the exposure to the insult. So going back 10 to 15 years, we've had good quality mobile phones for many years beyond that. So we should have seen the rise by now if it was to be a significant impact. And I guess we've seen the New South Wales Cancer Institute data on the incidence of brain tumours, and really it's about a 1% increase over the last 10 years. If mobile phones were really going to have an impact, then that would be a much higher rate by now. And the other thing is radiation-induced cancers, which we need to mention in our patients who have got IDH-mutated tumours or favourable subtype tumours, that there is a theoretical risk of that. It's in the order of about, depending on age, about 1 in 1,000, 10 to 15 years after the course of radiation treatment. So it's a stated risk, but it's a significantly low risk compared to the benefits.
And as Michael Barton used to say, if there was a real danger from the phones, you'd be expecting a lot of increase in ear tumours as well, which hasn't happened. Sue.
Just some broader comments, and certainly agree with what's been said by both Michaels. So I think the causation of brain tumours is a really important and obvious question. And actually, when we look at the research across the spectrum, causation, treatment, supportive care, surprisingly little research actually dedicated towards such important questions. So that is certainly a focus for all of us and those particularly involved in research to understand the causes, the epidemiology. On a practical sense, what I would say to my patients is, as has been said by other panellists, really the vast majority of families, there is no hereditary link, and therefore your blood relatives, your children, etc., would not need screening. Yes, there are exceptions, but that's very, very uncommon. Thanks.
Yeah, we always take a detailed family history, but it's a tiny percentage of patients. Jacob.
Just to give my perspective, it's a very common question we all get. There's a long answer and there's a short answer, but usually the question is motivated by what could I have done differently? This is absolutely not something that has occurred because you've smoked, because you've drunk in your 20s. The simple answer is this is just one of those things, and sometimes there's no rhyme and there's no reason.
Okay. Larissa? So we can over here.
I was just going to ask, primary brain cancers are presumptive.
No, it's being filmed, so we just need to hear you.
Primary brain cancers are presumptive cancer under work health and safety legislation in New South Wales for firefighters. So I was just on the basis of PFAS foam. So I was just wondering if that was an area that you guys had any comment on.
I had a patient who was a firefighter who had support from the legal channels regarding that, and I was surprised because I didn't really know that much data on that. I thought there may have been an association with other types of tumours, but not primary brain tumours.
Yeah, I'm not aware, okay, of any hard data. All right, we've got a question sort of moving forward from causation, just about the activity of and the metabolism of the tumour. So someone has written, exactly how does one go about finding out about the metabolism of the tumour? And I'm not quite sure if that also bleeds into the growth kinetics, how fast the tumour grows. So perhaps if Michael or Jake want to say anything about.
It might be a question pitched at metabolism in terms of dietary manipulation. That may be the source of the question.
The person who wrote the question want to expand on what the specific... Just wait 1 second, wait for the mic.
Where its primary starts in the journey, it's like, can you expand on the travelling or where it's going, or, yeah?
So I guess that's a really interesting question when we're looking at the genesis of a tumour. Where in the parts of the brain do these cells arise? And there's been a lot of research done on that, where there are stem cells in the brain and where there is migration of cells from one zone to another zone. Because if you can identify those zones, then potentially you could treat those areas and try to stop new growth coming from that region. We are learning about that. We don't have anything which we can implement in regards to that. There is some zones in the brain where we know the stem cells are, and where there is migration, but they're also where we actually have to have neuronal proliferation and neuronal expansion as well. So we've got to be careful we don't treat those areas because that can cause potential harm as well, unless it's medically indicated. I guess the big question on that's coming through our meetings internationally at the moment is the type of infiltration these tumours have and the relationship to nerves. And that, in a very simplistic way, these tumours might actually try to impersonate neurons or nerves. And so they then hitch a ride on those nerves because the nerves thinks they're just part of their own system. And there's some really interesting work being done from researchers in the US to try to flesh that out further. Because if you think they're acting like nerves, then potentially could you turn the nerves off rather than turning the tumour off, and you might actually do something to slow down tumour growth. We're very early with that, but the research is very exciting.
Yeah, so while you might see an MRI or a CAT scan, it looks like you've got this lump of tumour in your head. In reality, these are really motile and dynamic tumours. The cells grow. They grow along pre-existing pathways. They grow along the nerve fibres. And as Michael was saying, for when he's looking to where the tumour is going in terms of where to treat, they grow along blood vessels. And so they can disseminate through most of the brain with a malignant tumour, glioblastoma. So while the gross total resection that you've heard about from the neurosurgeon, they take out the area that's contrast enhancing. And the contrast enhancement is just where the blood vessels are abnormal, so the contrast leaks out. But there are a lot of tumour cells that you can't actually see on the MRI that are sort of percolating through the brain. There's a concept of doing a supramaximal resection where you try to take out the bits around the contrast enhancing area, but of course that's mitigated by maintaining function. And as you heard before, it's this balance between removing the tumour and maintaining function. And even when they've taken out, years ago, whole hemispheres of a brain, thinking they could stop the tumour, it's already moved over to the other side. So the concept of being able to cut it all out is false.
Sue?
Just I think to add to those comments, I think that really is, to me, the holy grail, and I think Michael Back referred to that in his talk, the ability to predict in advance of time where and how and when the tumour is going to track. At the moment, I think we have what we call a number of biomarkers, be they scan-based biomarkers like an MRI, like FET-PET, like special types of MRI. We don't really have a go-to blood-based test at the moment, but obviously there's a lot of work and research towards that end. And I think just philosophically, I think at the moment I find we have something visible and we react to that. What we really want is something that we can predict ahead of time to be able to then change the outcomes and the pathway for that patient. So we're not there yet, but a lot of work is being done in that regard.
I'll bring a question forward because it pertains to what you just said, Sue, and it also touches on some of your talk, Michael Back. The highway of the tumour and what is possible in knowing and strategies to prevent and help in its journey. So knowing the prediction of what tracks it might go down, how does that change your radiation planning?
Yeah, we're still learning about all that, but we try to get some information from the imaging to predict where these things are, where the tumour cells might be infiltrating, and they're these white matter tracks which extend through the brain, and they come from certain zones. And as we've done these connectome studies, which are looking at the small pathways in the brain, we're seeing that there are very unusual connections between the brain. And we see that occasionally when you do an operation on a patient and they lose their speech afterwards. You think, how come we've lost speech in that area where we weren't expecting there to be a speech zone, but there's a linking pathway to the other side. So part of the complexity is they might vary between people, and secondarily there's just so many pathways. But if we look at the major pathways, there are certain areas of the brain which we're hoping to identify that if we're treating a tumour in one area, we might be able to push the radiation dose to that region, or get Jacob to do a biopsy just in the tissue beyond where the tumour is to see if there are tumour cells infiltrating in that region. But also the neuro radiology is improving so much in the different sequences that we're actually getting better at predicting that through non-invasive techniques. We can, through the software that Sue and myself use, we can now steer dose down certain pathways. So we don't have to be stuck by having everything purely geometrical and symmetrical. We can be very asymmetrical, and we can give higher doses and lower doses to areas based upon risk. It might end up coming down to a mathematician working out probability statistics. And that's going to be the challenge, and as one of my colleagues, Jamie Drummond, always tells me that these scans are really not images, they're actually just a whole series of numbers. And so if you can work out the numbers, you can work out the what those numbers mean and where there potentially is tumour or where tumour's going. We've got some ideas. We're doing some basic stuff in terms of the way we're designing treatment. But I guess more and more, we're no longer radiation oncologists who can manage breast cancer, bowel cancer, esophageal cancer. We've actually got to be radiation oncologists who are managing brain tumours. And so we have to be very subspecialised now because we need to know what he's done. We need to know what Anette is going to do. And we also need to be able to know what the radiologist means.
Okay. Jake.
Really fascinating question, that concept of what will happen with the tumour, where its vector of growth is going to be. And I'd echo exactly what's been said, but surgically, it informs what I do up front increasingly. Whereas 10 years ago, the concept was gross total resection, take out the white lump. I think now the overarching concept of a supramarginal resection, if safe, especially along white matter pathways which may predict tumour growth, that's increasingly necessary, and we sort of need to push that a little bit further, because even though Michael's point about, there are cells that have tendrils that have extended out, I fully take that point, but there's no doubt that supramarginal surgery does help progression-free survival. There's no doubt about that. And knowing the highway, knowing the vectors of predicted growth is starting to be necessary for me.
And Jacob, when you say supramarginal, so how far away from the margin might you go?
It depends where the tumour is, and it depends on the eloquence of the brain. It depends on what we call, it's a cold term, but the performance status of the person in front of us. That's just the technical phrase for how well they are, how functional they are.
Jake, why don't you define eloquent brain for the audience too?
So eloquence just refers to parts of the brain that do important things like create movement, interpret vision, interpret or create language. So for most of us in the room who are right-handed, as you know, the left side of the brain controls the language centres, the language interpretation, the language production. If there's a tumour that is involving or very close to a language centre, that's going to make me a little bit more cautious in how I surgically approach it, versus on the other side of the brain, I might have a little bit more luxury to take a little bit more brain around a tumour in that same region, okay, the mirror region.
Okay, thanks.
So eloquence is important, and unfortunately it comes back to that tension that I spoke about in my talk. I want to remove as much as I can that I believe to be abnormal, but balanced against that, I want to maintain crucial function, vision, language, movement.
Thanks. All right, this is a question for both Dr. Rodriguez and probably Dr. Tognela as well. When should a patient request molecular profiling? When in the treatment journey? So Michael, why don't you tell us about what happens often automatically or up front, and then Annette can talk a little bit more about the CASP and most stuff that is an add-on.
Well, currently in New South Wales, or certainly in metropolitan Sydney, all brain tumours get molecular characterisation. So they all go for next-gen sequencing. There are a number of different panels. The one we use is a 100-gene panel. It's covered by Medicare. There's no cost to the patient. There are additional molecular tests that can be done, which in some cases may be useful, but for the diagnosis and prognosis of most brain tumours, the panels that we use routinely are more than adequate.
And I'll follow on from that. So when I was talking about the CASP and the most testing, ideally it would be good to refer people early, so soon after initial diagnosis, so when they're first seeing medical oncology, referring to try and obtain additional information to see are there rare mutations that may be targets in the future. I think it's also important to think about it at the time when the cancers come back. If people have further surgery, that is another opportune time to test the tumour to see have things changed. So we do know, and what I highlighted was that molecular mutations aren't common, but if they're there, then it offers a potential target for the future. And I also think that it's helpful to know because maybe we don't know enough about these mutations right here and now, but if we identify more as time goes on, then down the track there are potential options for further studies, further treatment opportunities, and to really inform knowledge of what other agents we need to be looking at that might be important in stopping glioma growth. So early on, and I think at recurrence are the key points.
And Michael, we didn't have time this year for your own talk, but do you want to just maybe give us a quick headline overview about MGMT, IDH, and maybe 1P19Q? Just a sentence or two about those. Just because many of you in the audience who've seen a pathology report will see something will say IDH wild type, MGMT methylated, 1P19Q non-deleted. So just.
Thanks, Liz. Without a talk. So currently, brain tumours are diagnosed. They used to be diagnosed by looking down the microscope. A hemotoxin and eosin stain slide would make a diagnosis. In nearly all brain tumours now, they require molecular information. And so the pathologist integrates the molecular and the morphological information and gives an integrated diagnosis. Now, as you heard earlier, that can take time because for next-gen sequencing it takes a couple of weeks at least. So some tumours are defined by the particular molecular abnormalities that they have. So, and this is talking about primary brain tumours, you can divide them into two big groups, the ones that have an IDH mutation and the ones that don't. Now, the ones that have an IDH mutation, and that's isocitrate dehydrogenase, which is it's an enzyme in the Krebs cycle, the cycle that all our cells use to make energy. And for reasons that are not exactly clear, in certain tumours you get a mutation in the IDH gene, which causes it to have a different function. It makes a different product instead of the one that it should make. And that goes on and is essentially oncogenic. So identifying that mutation is really important. And IDH mutations confer a better prognosis than tumours that don't have an IDH mutation. Now, IDH mutant tumours come in two flavours. There are astrocytomas or oligodendrogliomas. And oligodendrogliomas are the ones that have the co-deletion of part of chromosome 1, the short arm, the petite arm, 1P, and the long arm, Q, because it's after P, of 19. So if they've got 1P19Q deletion and an IDH mutation, that's an oligodendroglioma. And they do better than an astrocytoma with an IDH mutation, and much better than a tumour that doesn't have an IDH mutation at all. What was the other one?
I said MGMT.
MGMT?
Yeah,
oh.
yeah.
Okay, so MGMT. A lot of brain tumours are treated with temozolomide. Now, temozolomide changes the DNA, and MGMT is an enzyme, and that reverses that change. So if you've got a functional MGMT gene, Liz can give them temozolomide, but then the body just, we'll get rid of that. So they reverse the abnormality. So temozolomide is not nearly as effective. It does have some effect, but not nearly as much as if this gene or this enzyme is not working. And so the way that we test to see if this gene is working, or this enzyme is working, to reverse the effects of the chemotherapy, is to look at the test is a MGMT promoter methylation study. So if the bit that controls the gene has methyl groups on it, the gene is silenced. So the enzyme is not made. And that's a good thing. So a methylated MGMT is a good thing. Unmethylated means the gene is functioning and can reverse the effects of temozolomide. Have I lost you yet?
Thank you for that.
Sorry.
I did put Michael on the spot, so thanks for rising to the occasion. Jacob, before you go, I've got a few questions for you. So, is there a limit to recurrence surgery? So how many times can you go back in? Or is it very much dependent on locations, impact, etc.?
That's a very good question, and it really is dependent on individual factors, where the tumour may have recurred within the brain, how well somebody is, because unfortunately every time there's surgery there is a price to be paid. There's a price to be paid not only in terms of risk to things such as movement, risk to things such as vision and language, but there's also a very subtle change that can occur with surgery, which is difficult to define. And I personally have operated on patients up to 4 or 5 times, but that's really pushing the boundary in somebody who has a tumour that's recurred in a favourable location, in somebody who's generally well. But I suppose as a rule of thumb, most patients who do have a recurrence, I would love to offer further surgery too, but it really does depend on that natural tension that I've talked about time and time again. I want to resect things, I want to create a situation where the brain doesn't have that big white lump in it, but I cannot do that at the expense of somebody's well-being.
Yeah, and it's hard when there's lots of foci as well.
Yeah. Another reason for operating again on a tumour, well, there are a number of reasons, but 2 main reasons are, okay, so you've had a brain tumour, it's been treated, something comes back on the scan. We're not really good at determining precisely whether that is necessarily tumour that's come back or whether it's related to the treatment. There are a number of ancillary imaging tests that can be done, but none of them are 100% certain. So you never really know. The other probably more important reason for reoperating, now that we're moving much more towards a personalised precision medicine, is that glioblastoma, which is the commonest primary brain tumour, is, as you heard before, is incredibly heterogeneous. So all the cells are not the same. Now in paediatric tumours they're slightly different because they tend to be all pretty much the same. But in adult tumours they're very heterogeneous. So cells next to each other can have completely different molecular makeups, different driving mutations that are causing the tumour to grow. So if you treat these tumours with radiotherapy or chemotherapy, you're going to select out clones in this tumour that can survive the radiotherapy or the chemotherapy. So the tumour, when it comes back, is not the same tumour as when it was first diagnosed. So if you're looking for a specific treatment, you want to look at the treatment of the tumour that you have now, not the one you had a year ago, which is molecularly different. So surgery can give us tissue to do more sequencing on to see if there's a different driver. There may be the same driver. To see if there are resistance mutations. That's much more common in, say, lung tumours, where the tumour can develop a resistance mutation to a particular drug. And also to tell whether you've got tumour or not, because sometimes the big lump that Jacob takes out is just dead tissue and inflammatory stuff without actively growing tumour.
A lot of what we've spoken about today is on the basis of people who present with, for instance, a high-grade glioma for the first time. And radiation is crucial in that circumstance, but often if tumours grow back, the options for further radiotherapy are quite limited. Okay? Options for chemotherapy may be similarly a little bit limited or a little bit deprecated. So if the question is asking, is surgery a real option for recurrent GBM, for recurrent high-grade glioma? Absolutely, it's got a valuable role, but it gives us information, it removes abnormal tissue, but we have to recognise that if things have grown back, it's also not always a good situation to be in.
Sue?
And just to add, I think that's where the power of the team, the multidisciplinary team, and the discussion about that decision, obviously together with the patient and their family, it's a combined decision because it's a technical one, a clinical one, a personal ethos decision. And sometimes it's not just, is surgery the decision, but it's actually what comes after that. So it's really a decision that's best made in a team. Let's just make one comment about the profiling. I think, in my mind, I mean, these reports are very technical, and we defer to experts like Michael Rodriguez to help us interpret those. In my mind, there's sort of two broad categories. When you look at these reports, they're very technically dense. In my mind, they give us information about prognosis, as in how we think the tumour is going to behave over time. The second group, they give us predictive information, so how will the tumour respond to specific treatments. And I think they help us determine treatment and care right now, but also into the future, what we would do and why we would do that. But I think there's also some information, it's a rapidly evolving space where we may not know exactly in 2024 what to do with that clinically. But I think it just tells us that the importance of obtaining tissue, even though it involves a brain procedure, is really vital. Because yes, the imaging and the scans can tell us some information, but really the tissue is really important because, as we've heard, it can change from the first surgery to subsequent procedures. Thanks.
Great. Yes, question over there, roving mic. Thanks, Victoria.
Thanks. It strikes me as the place we're headed to is the current standard of care, resection, temozolomide, radiation, and where this conversation is going around targeted treatment for a patient. It strikes me as strange that the CASP screening isn't done for everyone. I guess what I interpreted was there's current pathology testing that can give you 100 markers, but CASP gives you a lot more detail. You talked about IDH, MGMT methylated, and so on. It strikes me as the gap here is we waste potentially time not going down the path of the screening for everyone to give a better outcome of care, knowing more about the pathology.
So most are now CASP. Has been an evolving sort of grant, and it's become, it's just received more money, and I think most oncologists around the place know about it and are routinely referring. I might just, if you wanted to say anything, Annette.
Yeah, so I guess that with the CAS program, so it's open for all tumours in terms of molecular profiling, and the availability of it, as Liz has said, is evolving. So initially the program was looking at, can we do this? What are we identifying? And it was in people that had exhausted all previous treatment. It's now being made available earlier in the disease trajectory, but I think it is something that going forward we should be looking to do in most patients.
And I've had many patients over the years that have had most testing, and it's been interesting. I've sort of seen a list of mutations, but I can't think of even one patient that I've changed my, actually one patient I offered something that I wouldn't have because there was a high tumour mutation burden, but that intervention didn't actually help. So I think it is something that's more future gazing in terms of really impacting on how we treat you guys.
The other thing to remember is that these panels are targeted panels. It doesn't look at every mutation there is. And CASP is not targeted towards brain tumours, they can have lots of mutations and variations, but they're within a big group. So a targeted neuro-oncology panel will often give you much more information than CASP because it looks for things that you see in brain tumours, but not in the much more common tumours, say lung, breast, prostate. Would that be true? And there are lots of different neuro-oncology panels around. Bigger is better. Most of the targetable mutations are really rare in glioblastoma, for instance. So a BRAF V600E mutation is in less than 5%, 2 or 3% of tumours. Now, less than that. I was being... But even for something that uncommon, we do an immunostain for that. There's an antibody, cheap, quick, we can do it in a few hours, to look for that V600E mutation. So we can say that there's no V600E mutation. IDH mutation, 90% of those mutations can be identified with an antibody. If it's antibody negative, then we send it off for sequencing. So we do look specifically for the abnormalities in brain tumours. Ideally, you'd look at the entire genome, whole genome sequencing. That's not practical at all in a clinical setting, unfortunately.
There's often a list at the bottom of the CASP thing which sort of lists clinical trials that match those mutations, and at the moment most of them aren't really available for our brain tumour population, but that's evolving.
And the trials that get listed in CASP are for systemic tumours usually, so you've got the issue of things getting into the brain. The blood-brain barrier, it's a bugbear. Lots of drugs work for other tumours outside the brain, but getting them into the brain is a big problem.
Okay, I saw an arm up.
Yep. Hi. Can I ask Jacob, how do you decide how much of a tumour to remove? Do you have a discussion with, say, an oncologist who says, I don't think you should touch it, and then you might say, well, I think I could address this and come up with a good result? Or do you sometimes go into an operation and say, I think I'm going to do a substantial bit of surgery here, and then when you get in, you decide otherwise? What's the dynamic there?
Both. So I'm not being flippant when I say that. So I think it's fair to say that there is a surgical strategy that is in mind before we first put knife to skin. Sometimes that is informed by a multidisciplinary discussion, but also, to be fair, it's more the surgical judgment up front in conjunction with what the patient wants, which informs what we do. So, for instance, if I'm having a discussion, some people will say to me, look, I'm quite fearful and apprehensive about the prospect of any surgery. I am incredibly apprehensive about the prospect of any risk during surgery, and that means that we adopt a more cautious approach. We might err on the side of taking less of the tumour out, knowing that that decreases the burden of risk that something could occur.
Or none of the tumour out.
Sorry?
Or none of the tumour out.
Well, we need to take some of the tumour out in terms of getting a diagnosis. So there's always something that has to be removed. Mm-hmm. And there's always a seesaw between the more aggressive we are, that means more of the tumour is removed. That means we generally have better prospect of a good diagnosis, of course, but also that cytoreduction, removing the bulk of abnormal cells. But the flip side of that seesaw is that there may be more risk to the surrounding brain. Now, some patients may say, I'm incredibly apprehensive about any neurological problems, and other people might say, look, get this bloody thing out. I had a patient just last week who's come for his second surgery. It's a recurrent GBM that's very close to the speech area. He's completely content with not speaking if necessary, because he wants to be there for his grandchildren. And I suppose that's a valid perspective, as is the other perspective, okay? But you're right, once we're there, sometimes the situation changes. And if I'm operating and it's clear that I can't achieve what I aim to safely, then I might shift course. Okay. Does that answer your question?
Yeah, thank you. Thank you.
There's a question here. After diagnosis, does a new tumour grow that was not there at the start? We've sort of touched on that question, but it was directed to you, Michael, back, but does anyone else want to... Does a new tumour grow after diagnosis that wasn't there at the beginning?
Yeah, I guess there's a way of defining what a new tumour is, whether it's a completely different type of tumour or whether, unfortunately, in some tumours, Jacob might do an operation and remove all that's been seen on the preoperative MRI scan, and we do have this unfortunate situation where you get rapid early progression, which is a condition where you're getting regrowth in the sort of 3 weeks after an operation. It's just suggesting there's a high biological activity of the tumour. And so we see the surgeon remove something, and then we do our first design of radiotherapy, or we do a PET scan and we find something else differently, and we go back for another MRI and sort of map that out. So yes, it can happen. To get a completely different pathology, that's sort of unusual, and you'd be looking to see if the two are related. The other aspect happens also is that you might have your initial scan and you've got a lot of swelling and compression in the brain, and it hides something which might be further afield. And so once the surgeon has taken the mass out and the pressures come down, then you might see something else in the periphery. We spoke of relative costs of things. We didn't really speak of relative costs with CASP, etc. So with CASP, we're trying to find the molecular targeting, and we might pick up, I think the data is 1% in high-grade brain tumours. So you do 100 tests, you might find one abnormality, which might then be potentially have a target which could be treated if you can get access to the drug. So the yield of that CASP testing doing it routinely is pretty low. MRI and a CASP test for, I guess we don't really know the cost of a CASP test, but the foundation testing, through $2,500?
It's a few $1,000s, isn't it?
Yeah, so $2,000 if you want the test done in the US. It'll probably take you 8 to 10 weeks to come back. We don't do a lot of MRIs 3 weeks after Jacob does his operation, straight before they have their radiotherapy. And things change for certain types of tumours, not all types of tumours. So there's a relative benefit repeating an MRI scan if you've got the facilities and got the availability. 3 weeks after your initial operation might be really good in helping to decide the treatment pathway, or doing a PET scan for the study that Sue's doing around Australia. That might be a good investigation to do, and all of those are quantumly less cost than the cost of a foundation test or the CAF testing. So you've got to look at relative benefits to the patients and relative advantages, and sometimes doing a little bit more imaging beforehand might be a cost-effective measure to sort of make sure you're getting confidently you're not missing something day one.
So we heard earlier today that brain tumours are relatively uncommon. Sorry, there's a hand up, is there? Sorry.
Oh, yeah. I'd just like to go back to the white matter area where the cells could be following down the white matter pathways. I'm just thinking over time this could lead to disruption of white matter or problems with the white matter. So in long-term survivors, could you expect to see sort of cognitive issues or white matter-related dementia issues in patients?
Yeah, there appears to be a volume effect if we're treating down pathways as well as the total dose going into certain areas. Most of the longer-term effects which are affecting function are probably more going to be the cortical atrophy, where the rim around the edge of the brain rather than internal pathway, that can become thinner when you're giving higher doses of radiation treatment. And we've got a reasonable parameter of where we're at in terms of what we try to restrict down. Now, it's unavoidable for most cases. But if you can reduce that down, that's where you might then make a subsequent impact on cognitive function. The white matter tractors really, they might have specific neurological deficits, but it's usually not so much the scarring, but more if you actually get a disruption. So if a tumour causes an infarct across it, a stroke across it, or if the surgeon has to violate that area if it's a key pathway. The radiation treatment, part of the reason why we subject you to 6 weeks of treatment, you could deliver it all in one dose, but by giving it every day over a period of 6 weeks, we soften the injury to the normal tissues and we allow that to recover. So we can actually make an impact in protecting those areas and minimising the risk of damage by using what we call the fractionated treatment, or giving it over a period of 6 weeks.
Or 4 weeks for all.
Or the 3-week course. Yeah. So there is, in that way, we can actually protect by giving it in multiple treatments rather than one big treatment. But yeah, as part of radiation oncologists, when we're mapping out things, we want to make sure what we're treating is important, and we're trying to target that as much as possible. And that's where I guess I'm an advocate of very good imaging to try to help that.
Thank you.
Just on white matter, look, very simplistically, it's probably best to think of white matter as the cabling in the brain, because all of the signals get produced and there's processing in the grey matter, the cortex, and then they pass through the white matter to affect whatever they do down the track. So white matter is important because it is a bit of a highway where tumours can piggyback along with growth, but it's really not the processing part of the brain, it's the cabling, internal cabling of the brain.
I've got so many written questions here. I might just shut down the questions from the audience just so we can try and get through the questions that have been submitted. I was talking before about brain tumours being uncommon, but then there's within brain tumours even rarer presentations. So these next questions, I guess I'll start with you, Jacob, about thalamic glioblastoma. So how do you treat inoperable tumour like thalamic glioblastoma? And does diffuse thalamic GBM metastasize in other organs of the body? If so, how long does it take, or is it limited to the brain?
So when we talk about tumours being inoperable, on one hand, everything is operable, but there's a price to be paid. So if we operate in a place of the brain such as the thalamus, which is really like a traffic control centre where you've got lots of motor inputs travelling down and lots of sensory inputs coming up, if we operate there and operate aggressively, we can cause great injury and damage to those motor pathways or those sensory pathways. But operations still have to occur because we need to take some tissue so we get a diagnosis. So inoperable is one of those words which I use with a bit of caution. Okay, but clearly thalamic GBMs, they're very tricky because generally the surgical risk is so high that we can't achieve that aggressive resection, either a gross total resection or even a majority resection. And that means that we're behind the 8 ball with our other treatments like radiotherapy or chemotherapy. Okay? In terms of metastasizing, look, thalamic GBMs, because we're behind the 8 ball from the beginning, it's fair to say that often the course is a little bit more difficult. Not because the tumour travels to other parts of the body so much, but because it tends to grow within the thalamus more aggressively, and that creates problems with movement and sensation and cognition. GBMs don't usually move to elsewhere in the body. They can in some situations, but it's very, very rare.
Yeah, sometimes if there's a shunt, I've seen one case go to an abdomen and one case go to a lung in many years. While we're talking about rarer tumours, Michael Back, what are the long-term effects of repeating radiation treatment for recurrent meningiomas?
Once again, you've got to individualise where things are at and which part of the brain. We do have sort of parameters of what parts of the body can repair a little bit after radiation and to the extent of repair, so you can give more dose. You've got to look out for areas around the base of the skull where you've got the nerves to the eyes, because you're sort of fairly limited of what you've given beforehand. And then if you have to add on more dose, then you've got a higher risk of getting a stroke in that area. And the more catastrophic stroke could be something where you're getting total blindness. So there are certain areas that Sue and myself will sort of target, define really well, know what the dose is to there, try to minimise the dose to there. We tell our programs to minimise the dose to those areas. And if we have to add on dose afterwards, we know we've got a little bit of room to move, but not a lot. The biggest issue with repeating radiotherapy, and we now do a lot of it, it is an effective treatment for many tumours, and including tumours like meningioma, you can potentially re-irradiate, is that you are increasing the risk of an inflammatory response and swelling afterwards, a condition we call necrosis. So the cells die off and the body doesn't take that away. We've got some strategies to deal with that, but that is the biggest risk. Once you're going into a further course of radiotherapy in the same region you've treated before, then you're really increasing that risk of bad swelling and stroke. So I think at the moment we're discussing our treatment with patients, we might say a 2% to 3% risk of a stroke, 6 to 18 months after the radiotherapy. If we're re-irradiating, that risk goes up to about 20 to 25%. But you can do some things to try to minimise that, but that's when we re-irradiate, we're usually coming off the bench because Jacob can't do anything, Annette can't do anything, Michael's finished. And so we're actually re-irradiating when there are difficult times.
Right. While you're in the hot seat, Michael Back, do you have something you would need to say?
Just to echo Michael's comments, I think there's a dose effect, there's a volume effect, and there's a time effect. So it's really integrating those important factors together with the patient and in the team. And I guess in that setting where we're looking at retreating, the tumour cells are likely to be more resistant to the treatment the second time round. So everything becomes a bit more challenging, but it's certainly technically possible.
Sue, while you're holding the mic, why don't you elaborate on what pseudo-progression really is?
How long do we have? Essentially, pseudo is like, and progression is trying to, I guess the main thing is understanding, is it true progression or pseudo-like progression? It's a phenomenon where it tends to happen quite early after, for example, for a high-grade glioma patient having radiation and chemotherapy, there's a treatment swelling effect, and we can see that patients can have clinical symptoms. We can see on the MRI that it's quite a swollen area, and we're just not quite sure, even with expertise and with great MRI radiologists, what does that represent. So I think it's a clinical challenge. It basically is down to the expertise of the multidisciplinary team. If patients have symptoms, they may need to be managed with the right dose of steroids for a shorter period of time just till things settle down, and ultimately time is going to be the arbiter. It tends to peak within that 1 month after radiation finishes up to about 3+ months afterwards, and then it tends to settle down. So I think it's about awareness, it's about being looked after by an expert team who understand the chronology or the time sequence of events and watching things very carefully over time. It is a difficult challenge, but I think it's about being managed in a good team and holding our nerve and managing people appropriately with the right imaging at the right time points.
And sometimes the pseudo-progression can be a good thing because you're mounting an immune response to the tumour. So when I've given talks on this before, I've given a slide saying it can be a good thing, and there's some data to show that if you mount a good immune response, that might improve outcome. But the next slide is you've got to survive the pseudo-progression, because it can be really bad and it can cause a lot of morbidity. And that's where the challenge comes with our treatment. We can deliver treatment, but it's around that month after treatment, 3 months after treatment, we really need to have a good team approach at managing the problems if people get significant swelling. And in our patients with glioblastoma, we expect that 15 to 20% of people will get significant steroid refractory, so steroids don't work anymore, symptomatic pseudo-progression.
And I'd just like to add, from a medical oncology point of view, we also see pseudo-progression with some of the drugs that we use. So bevacizumab or Avastin, often when we are doing scans, we get phenomena of pseudo-progression. We're not sure, is this really true? And patients might have pseudo-progression whereby they have symptoms, and trying to tease that out is really quite challenging. So it occurs both with subsequent to radiotherapy, but we also see it with some of our systemic treatments.
Yeah, and bevacizumab can also cause pseudo-response, where it looks better than it really is as well. Okay, Annette, with you, but other people might have experiences with their patients. What current prescriptions or over-the-counter tablets have shown any indications that they slow or prevent cancer regrowing?
Oh, this is a hard one. So I think there's my experience, and Liz, I can fight me on this, that I think there's very limited evidence really in this field in terms of showing over-the-counter. I know that in the past there's been some studies that have looked at ivermectin, worming tablet, that has, and its impact on GBM, but I think the data is not particularly convincing. And so I think really the role for over-the-counter is probably more in supportive treatments rather than in tumour, in arresting tumour progression. There's also been some studies around using cannabis products, and I often have people ask me about using the cannabinoids, and again, I think the data really isn't robust enough for us to be able to provide advice in this setting.
It might help with sleep or appetite, but generally there's no hard evidence in the glioblastoma setting. Jake?
I might just talk about this for a second, because I spoke in my slide about hope, and often people with GBMs, their families, they're a little bit bereft of hope. It can be a desperate situation, and unfortunately, when you type into Google, there's a whole host of websites that come up, some of which can prey upon that hope and provide, I feel, false promises, sometimes at significant cost. So my suggestion around that is that hope exists, but it's important to have good conversations with your oncology team that you trust, rather than just take at face value all the information that you may get from other avenues.
I was just speaking this morning to Helen Wheeler from North Shore, and she was saying that some of her patients have spent between $300,000 and $500,000 going to Germany for something that's never been published. They won't. If it's that good, why aren't they publishing? So we've got to be very careful about what we do. And Annette, or you? Okay, I might combine just because of time. I might just read out 3 questions. And Annette, you're really on the hot seat here, I'm afraid. There's some really tricky ones here. Okay, so could you share your views about the different paradigms used for immunotherapy treatments? More specifically, what do you think about dendritic cell therapy and oncolytic virotherapy? That's question 1. Question 2 is there is a lot of discussion about Germany creating a vaccine. How close is this to trials? And inevitably, how soon is Professor Scollier's immunotherapy treatments going to be available for current patients? So why don't you jump into that Pandora's box?
So I guess when it comes to things such as oncolytic viruses, the data there, so there are some early studies that have been conducted. So there was a phase 1 study which is showing a signal in terms of potentially improving outcomes. But I think it's still very early days, and so that particular study, one's using a deactivated polio virus, is looking at moving into phase 2 trials. Unfortunately, most of these trials are available only overseas. DC vaccines, so dendritic cell vaccines, so using dendritic cells, the immune cells for the brain, and injecting them, and using those by injection has been shown in some studies to be beneficial, but those studies that have been conducted, and one was a large phase 3 study, there are some issues around the study design, and also so those, as far as I understand, are yet to become available. So I would say that there's still a work in progress. Liz, I don't know at this point if you...
Yep, the other one was the German vaccine.
In terms of the availability of that, I'm really not aware of where that's up to more generally. And again, the amount of the actual study that looked at that, there have been some concerns expressed about how the study was conducted. So I think there is still, that raises probably more questions than answers at this point in time. And then I think the last one is on Professor Scollier's treatment. So just recently I've seen a publication that actually outlines what treatment Professor Scollier has been receiving. So my understanding of it is that after his diagnosis, and he was diagnosed with an unmethylated GBM, so less sensitive to temozolomide, and prior to surgery he received an immunotherapy drug combination using 3 immunotherapy agents targeting different parts of the immune system. He then went on to have his surgery and then I think subsequently radiation. And then subsequent to that, he's had more of those immunotherapy agents, initially only 2 because he developed a toxicity to one of them. And then I think subsequently that third one's been added back in. But in addition to that, he's also had a personalised vaccine after his surgery, and to which I'm not aware of the specific details of that. I'm really hopeful that Professor Scollier has a great outcome, and I say that both for him personally, but also in terms of providing options potentially for our patients with brain tumours. But I think the challenge that we have with the treatment that he's received is that is a very intensive course of treatment, and which part of that treatment is the key? Do we need to give the whole kitchen sink before surgery, after surgery? How long do we continue it for? And using immunotherapy, and particularly 3 agents, is quite toxic. I treat patients with other tumours, and immunotherapy isn't without its toxicities, and potentially the side effects can be life-threatening and in some cases sadly fatal. So people being able to tolerate 3 treatments plus a vaccine would be sadly a very select group. I'm hopeful that potentially what this study will do is maybe start to inform how we design trials, whether that be using immune therapy prior to surgery and looking at what the different outcome that will be. So in terms of availability down the track, I think that is still a very long way off, unfortunately. But I did see a press release that they are looking at potentially opening a trial, but I know no further details at this stage.
A tiny bit of quick context. It's been pinched from melanoma, this approach, because both Georgina and Richard are melanoma researchers. And my understanding is that particular combination of 3, most people only get through 2 cycles because of the extreme toxicity. There are people who end up on dialysis, on ventilation, in ICUs. So it's actually very toxic. So often people, think, oh, it's because of the money that we're not getting this. It's not about the money. It's about the toxicity and the safety. I think as Jacob had in one of his slides, safety first. And that's why we're waiting, not because it's too expensive.
Liz, can I add some comments to that? I'm not sure if others want to. I think Professor Scollier's case, in my mind, there's 2 main... I look at it in 2 main facets. One is the human story, which I think everyone in this room resonates with. But in my view, his story is no more powerful than your story as well. The difference is that he obviously has a public platform, which not all of us have. That's one component. And I think on a human level, we wish him all the best. On the science, the second component is the science. And I think with N=1 patient in a trial, we would all understand that that needs further critical appraisal. And so I'm open-minded. We're all looking for a potential game changer. But I think we watch it with interest. And I understand the questioning and the desire. So I think it's a difficult line to walk because we all want to improve outcomes. We all connect with the human story, but we're also clinicians, researchers, and we're looking at from a science's perspective as well. So I just wanted to frame it in that way because it's helpful in my mind to kind of approach it using that frame.
I'll be a little bit limited to what I say because I look after Richard, but I can quote what he's put on his posts, which is public knowledge. And I guess you've seen, if people look at his posts, you've seen his scan. He presents differently to a lot of our patients with glioblastoma. So he was able to have a biopsy and then have other treatments before having his definitive surgery. But as Jacob is aware from his patients, etc., people have come through, a lot of patients come through with a large mass effect, and you need to get the mass down. So you don't have the opportunity to do a biopsy, wait 10 days for all the results, start a novel therapy, see how that responds, do another operation, get the details, and then proceed to standard treatment. So in Richard's story, it's a little bit different than the way I would see the majority of our patients do present. But that doesn't mean we should close the window for that subgroup of patients who present with a seizure and a predominantly non-enhancing tumour. We have to look at individualising the care, and this might be an option to do something novel, and that's getting a tumour sample and then delivering a treatment and see if that treatment works is kind of a nice approach, which has been done in recurrent disease, but less commonly in advanced initial diagnosis of disease. So that's where Richard's approach has got some novel aspects, but if you run a trial, the majority of patients may not actually be eligible for that. But as Sue's mentioned, he's very brave, and it's a very taxing treatment. We've done randomised clinical trials with immunotherapy across the world and in Australia, and in fact, Sue's Cogno group, which we're all part of, ran a study in the elderly population, was very brave, giving 1 drug, and we had to watch closely because we were worried about things. Richard's taken 3, and a vaccine as well. So he's very brave in doing it, and he's a strong man, and he's at 12 months, he's managing okay.
And the other thing to remember is that there have been a lot of immunotherapy trials for glioblastoma over the years. None of them have really worked, but in all of them, including the polio study, there are occasional patients that survive. We don't know why. So there's an awful lot we don't know about this condition. So yeah, it's really tempting to look at Richard and think, I want to go on that. But for the reasons that you've heard, that's not really practical. And with an N of 1, we don't know if he's that one person that's the tail that would have survived whatever we gave him, whatever he took.
Can we just give a round of applause for Jacob, who needs to run off? I'm a bad chairperson. We've gone a little bit over time. This was an experiment, moving the panel session back to 1 hour. It clearly needs to stay at 1.5 hours, which it's been in the previous years. I'm going to defer one of the questions about Lumos 2 to this afternoon when Siu's speaking. And likewise, Sue might tell us a little bit more about this when she stands up. And we've got a little question and answer session at the end of the afternoon. So the question about research about glioblastoma survivors, we'll talk a little bit about later. But we're really lucky in Australia, the tight-knit community that we've talked about. Cogno is a broad umbrella of psychologists and rehab physicians and occupational therapists. And so there is actually fabulous research being done, and Megan Gion's going to be speaking this afternoon about some research about the survivorship and the symptom aspects of living with a tumour. Do you want to say anything quickly, Sue? Or, yeah, okay, all right, great. All right, so we'll come back to that this afternoon. I might combine these three questions, and some of it I think will be best for Sue to start to kick off with. And there's a little bit of very similar wording here. So it's been years we've been researching the cancer treatment. Why is there a poor prognosis for brain tumours, especially malignant ones? Is it because there's less trials being performed or there's less funding for the study research? That's question one. What are the current best chemo treatments for glioblastoma we've created many years ago? Why has there not been better treatments available for so many years? Has there been some found and provided to pharmaceuticals but not available? And then the next one, but I think it's all sort of the same, similar questions. What is the best way to get research groups, cancer groups and governments to get pharmaceutical companies to provide drug therapies that have been proven to be effective? How can we remove the focus on them for profitability? So, big topic. So I'll just see if Sue can elegantly attack some of those three questions.
That's fantastic questions, and we spend our entire careers really trying to shift the dial on those. So I think that the challenges are multiple. One has already been heard this morning, the biology of the tumour. The fact that it sits in the brain, we have the blood-brain barrier which protects us when we're healthy, but represents a barrier when we want drugs and other treatments to actually directly access. So we have the biology of the tumour, what we call the heterogeneity, so it changes over time, and even within the one tumour, as Michael Rodriguez has mentioned, it's a heterogeneous tumour. So there's the tumour biology. I think then we come to the funding aspect, and certainly I think brain cancer and brain tumours are having more of a profile in the public mind, and that's a positive thing. I think the government has led a number of initiatives with other philanthropic groups to almost bring together some catch-up funding vehicles. For example, the Australian Brain Cancer Mission, which has been a substantial portion of funding to specifically look at funding research into brain tumour trials and understanding and obviously interventions that have an impact on survival and quality of life. But certainly, in my view, it's not enough, and we need to really continue to advocate to all the relevant jurisdictions and government bodies, as well as philanthropic groups, about funding. I think I'm going to touch on this afternoon, but the clinical trial design, and we've touched on it this morning, I think that the paradigm was one trial, one treatment, closed trial, it didn't work, what's the next trial? And you can imagine the resources, the time, the funding to read out that trial might take us 5, 6, 7, 8 years. That's too slow. We have to be thinking about innovative, different trial designs like GBM Agile, like Lumos 2, where we have a platform to which we can then add arms over time and interventions, because that speeds things up. It will help hopefully identify interventions that have a signal, which we can then progress to larger trials in more patients. And equally, the flip side of the coin is, if something is not working, we actually close it early and turn our attention and our resources to other things that do have more promise. So I think the clinical trial element is also really important. So.
Yes, well done. And I think in terms of can we shift the pharmaceutical companies' focus from profitability, Sue and I have been active in the background. There's, for example, a drug in glioblastoma called lomustine, and there's been some predatory behaviour in the United States where because a company bought the rights from it, it's kind of like an orphan drug for a rare indication, and they increased the price by 1,500 times. And so we're desperate for that not to happen here, and it particularly impacted on some studies that Cogno's running. And so we actually have succeeded in finding a company that's going to be giving it in Australia for very reasonable, reasonable cost. So there are all these things that are going on, in the background all the time. But I just want to reassure you, there's a lot of advocates, whether it's BTAA, whether it's Cogno, whether it's Co's Neuro-Oncology Group or the New South Wales Neuro-Oncology Group, people who are going into bat and making sure that the right thing happens. Thank you for...
Liz, could I just add to that? I think the relationship with industry, pharmaceutical companies, is a really important and a challenging one, because I think obviously the agendas for clinicians and researchers are not always exactly going to align with the agenda for pharmaceutical companies. But that said, I think, and I'll touch on this afternoon, I think there's really a host of potential industry partners both within Australia and internationally. We need to work together. I think objectively the challenge on their side is that because the absolute number of patients having primary brain tumours is small, the financial case is potentially not that strong. So I think it's about Australia and more broadly us building strong research groups, demonstrating that we can do the science well, deliver the trials well, and make Australia an attractive place to bring and have those relationships. So I think it's certainly an area that we are looking to develop more strongly.
And there are definitely some good eggs in that world.
And I think we also shouldn't underestimate the importance of patient and consumer advocate groups. In a lot of cancers, they've made a key difference in getting drugs to market. So whilst we might not have that plethora of drugs available yet in Australia, when we do have something that's promising, I think it's really important that we advocate strongly for these medications to be available, and that's through government lobbying, and I think that is really quite important.
I'd like to thank the panel and thank you all for your fabulous questions. So Michael Back, Michael Rodriguez, Anette Tognela, Eng-Siew Koh, who's going to be speaking this afternoon as well.